Welcome to Biocanic's Health Intelligence Exchange community, where leading practitioners in integrative health approaches will discuss how they solve the most challenging and common health issues. These regular Q&A discussions are designed to take a deep dive into case studies and integrative approaches in order to elevate the collective knowledge of both experienced and new practitioners alike. Biocanic's Health Intelligence Exchange, your community for functional medicine.
Welcome to the Health Intelligence Exchange, everyone. I'm Lainey Gray, Strategic Accounts Manager for Biocanic, and I'm joined today by our guest, Jenn Evon from Diagnostic Solutions Laboratory. Today, we're going to discuss how the StoolOMX expands the clinical value of the GI map. Make sure you subscribe wherever you're watching or listening so you never miss an episode. And for those of you joining live today, we will be transitioning to a live Q&A toward the end of this presentation. So feel free to start posting your questions or comments below. Our guest today is Jenn Evon, a member of the clinical education team at Diagnostic Solutions Laboratory. Jenn holds a master's in human nutrition and functional medicine from the University of Western States and is a certified nutrition specialist through the American Nutrition Association. She is passionate about empowering both practitioners and patients through education with clinical interests that include gastrointestinal health, hormones, healthy aging, and behavior change. Hey, Jennifer, welcome. How are you?
Thank you so much, Lainey. I'm doing well. How about yourself?
Doing great. We're going to keep going here because we want to talk a little bit about where you work. So you work for Diagnostic Solutions Lab, also known as DSL, and they are a leader in functional diagnostics, best known for the GI map stool test that uses qPCR technology to assess microbes, digestion, inflammation, and immune markers. DSL has continued to expand with tools like StoolOMX add-on panel for bile acids and short-chain fatty acids, giving practitioners the insights they need to deliver more personalized and effective care. So let's jump right in. All right, Jenn, for listeners who may be unfamiliar, can you briefly explain what the GI map test measures?
Absolutely. So you gave a little bit of an introduction already, but the GI map is our comprehensive stool test. We're using quantitative PCR, so that allows us to quantify different microbes within the GI tract. We're looking at commensal bacteria, but then also things like pathogens, parasites, fungi and yeast, as well as opportunistic bacteria. And then, as you mentioned, we're looking at other markers as well. So we have a nice intestinal health marker section that assesses things like digestion, immune balance, inflammation, to really give a nice comprehensive view of gut ecology.
Awesome. Now, because we have a lot of practitioners that use this test and people that may not, how do practitioners use this in practice? Like, when is it appropriate to order a GI map test for their patients? Is this something everyone should run? Is there a use case? What do you see and what do you recommend?
So I think a lot of practitioners will gravitate towards the GI map, of course, for patients that are presenting with GI symptoms. So that could be common complaints like gas or bloating, changes in bowel habits, constipation or diarrhea. But as we know, the gut is so intricately connected to so many systems in our body. So I really think you could make the case for using the GI map for a wide variety of patients. We can think about the gut-skin connection. So using the GI map to shed light for patients that might have acne or eczema or psoriasis. The gut-brain connection is another really big topic. So thinking about your patients with brain fog or mood disorders, fatigue. We can even think about patients with metabolic conditions as well. And so yes, GI, but then also kind of sky's the limit in how you could use the GI map in practice with clients.
Amazing. Yes, we've talked about that many times, about the digestive system and the GI tract being linked to every piece of health. So I'm glad you touched on that, because many times people think, okay, I've got GI distress, I have these GI conditions, we should see what's going on. but more often than not, the other conditions, the skin conditions, the mood conditions, the hormone imbalance, the metabolic dysfunction is also intricately linked to the gut. So that's pretty powerful. Now, what is the StoolOMX add-on panel? So that's something different, and there's some additional insights. So what does that provide beyond the typical GI map test?
So we launched the StoolOMX add-on earlier this year. It is an add-on to the GI map, so you'll see it at the end of the GI map report. And within this add-on, we're looking at bile acids and short chain fatty acids. So StoolOMX is a play on metabolomics. So thinking about metabolites that are produced by microbes and considering those health effects as well. So within the bile acids section, we're looking at primary bile acids, which are produced in the liver. And that's typically what people think of when they think of bile acids is the primaries. They help with fat digestion. But then we also have this group called the secondary bile acids. And those have a lot of health effects as well. And they are converted, they're created by our gut microbes. They go through a certain process to turn primaries into secondaries. Then we have our short chain fatty acid section, and that can actually be broken out into two different groups as well. So when we talk about short chain fatty acids, a lot of times we're talking about what are actually straight chain fatty acids technically, and that's when microbes ferment carbohydrates, fibers to produce these fatty acids. A lot of times we'll talk about like butyrate is a big one. We have acetate, propionate, for example. But then we also have this other group called branch chain fatty acids. And those are the result of protein fermentation by certain microbes. And they can have some clinical implications as well.
Oh, that's okay. That's fascinating. I think especially, I love that you touched on the bile acids piece because we often think of that as a liver product only and not understanding that the gut microbiome does some action, has some action in there too. So I like how you explained that there's a secondary part to the bile acids. Short chain fatty acids, we probably know about because we talk about those kind of, through the industry. But tell us, why should we be measuring the bile acids and short chain fatty acids? Why is that important in understanding digestion, microbiome balance, and motility? Like, how do those play a role in our complex cases or even just our average cases?
Absolutely. So the secondary bile acids and the short chain fatty acids are produced by our microbiome. And so in that sense, they can give us a view into how our microbiome's doing, what diversity is like. We can expand our view beyond the microbes that we measure on GI map. We measure a lot of microbes that are capable of producing these products, but not all. And so this does give us that expanded view there. These products also can act as signaling molecules. So they act on different receptors throughout the GI tract. And that's a big way in which they elicit positive effects. So they can have effects on motility, for example. We see in proper balance, it can kind of help with the flow of proper movement through the GI tract. But if there's too many primary bile acids, we might have faster transit, diarrhea, low levels of short chain fatty acids, low levels of the bile acids. We could see slower transit. And then they can also help to modulate and balance out that microbiome as well. Bile acids can have antimicrobial effects. Short chain fatty acids can influence the pH, and that can really influence what types of microbes thrive and which microbes, have more difficulty. And typically those are going to be our opportunists. So that's a good thing. We want the short chains. And so really, if we think about their actions throughout the GI tract, there's so many different ways in which they're helpful for us. And research is continuing to expand, especially for those secondary bile acids on, the benefits that they can have for us.
Amazing. So correct me if I'm wrong. So you were talking first about in the GI map, we're measuring different levels of specific bacteria that are present. Right. So we're getting that we know they're present and we know that their job is to produce some of these different factors. but
Mhm.
we don't really know how well they're doing it. So that add-on, the StoolOMX, gives us a better picture to say, oh, they're doing a good job. Would that be a clear way to talk about why that's important to add on?
Yeah, exactly. And then there's also some bacteria that are not on the GI map that also help with that production. So we
Okay.
can get those
Okay.
indirect clues, kind of that expanded view of the
Yeah.
microbiome as well, an additional check-in
Okay.
into, yeah, how are these microbes doing for us?
Okay, that's fascinating. I love that. Can you actually back up just a little bit and tell us and kind of explain to us what bile acids are and what their primary role is in digestion? So, first talking about those primary and then the secondary once again.
Yeah, so the primary bile acids, again, those are typically what folks are going to be thinking
Yeah.
of traditionally. They are produced in the liver from cholesterol.
Okay.
And then they are conjugated with glycine or taurine. So conjugation just means glycine, taurine is attached to that bile acid, and then they're stored in the gallbladder. When we eat, they are released into the small intestine, into the duodenum, and they really help with the breakdown of fats, but then also fat soluble vitamins. So we want to think about that piece as well. They help to kind of emulsify, break down the fats. So if you think of dish soap and how
Yeah.
we use dish soap, it's very similar action there. And that conjugation, the addition of the glycine or the taurine, helps to make them more water soluble. It helps with that dish detergent breakdown
Okay.
property. So that's kind of big piece of digestion. And then actually most of those primaries should be reabsorbed at the end of the small intestine, and they are recycled back to the liver to be reused.
Okay.
So that's kind of main action of the primaries. And then secondaries, a small portion of those primaries will make their way into the colon. Bacteria are going to metabolize those and convert them into the secondary bile acids. Some of those are going to be reabsorbed, but some of those will make their way into stool. So ideally, in normal physiology, in stool, we want to see a low percentage of the primaries because, again, most ideally should be getting reabsorbed. We should expect to see a much higher percentage of the secondaries. And on StoolOMX, we actually do measure the total, and then we look at the percentage balance. So you can kind of get a sense of if things are where they should be, or if we're starting to move into a territory of imbalance.
Okay, so can you kind of expand on that? Though, what would cause too many of the primary getting into the next phase? You
Mhm.
know, if too many are not being reabsorbed.
Yeah, so a couple things can be going on there. First, we could look at the liver, and there is this feedback loop involved in the reabsorption and then the release, the synthesis of new bile acids. So if there's heightened production from the liver, and or if that feedback loop is disrupted, we can have increased bile primaries making their way into the colon and into the stool. We can also have malabsorption. So in that terminal ileum in the small intestine, if there's malabsorption there, they're not able to be reabsorbed. Of course, we'll see that spillover effect into the colon.
Okay, amazing. Thank you for clarifying that. So,
Absolutely.
how can these imbalance, if we have an imbalance in the bile acid levels, how does that contribute? So now these have made it to the colon, and you're assessing these on this new panel, and we have an imbalance of the levels as to what we would expect to see or hope to see. What kind of symptoms are we going to have?
So they have a big effect on motility, and motility can
Mhm.
also have an effect on what
Yeah.
we see. So part of this is we always want to get a good health history and know what's going on with the patient. But if we have high primaries, often we'll see diarrhea, we can see bile acid malabsorption, and that can be in patients with IBS-D, for example. Actually, research shows that up to a third of patients that have been diagnosed with IBS-D actually have bile acid malabsorption. And so, depending on your patient population, that could be huge. It's
Yeah.
underdiagnosed, so that can be quite impactful. We can also see excess implicated in inflammatory bowel disease. So if we think about bile acid malabsorption, of course, it could be loose stools. Along with that, it might be urgent bowel movements, might be abdominal pain or cramping, bloating, gas, nothing that we want, no good. But then on the other end of things, if we have low levels, so lower bile output, that typically will see slower transit, constipation. That also can come, with gas, bloating if someone is having slower transit as well. And then with the secondaries being low, again, since those are produced by gut bacteria, we want to think about if there's an insufficiency dysbiosis. So if there's not enough of those commensals, and that can be just as impactful as, a lot of times I think with GI imbalances, we're looking for overgrowths or infections, but it can be just as impactful to not have enough of those commensals. So patients could also have altered motility, maybe food sensitivities, a whole host of imbalances there.
Okay, so I'm going to ask a question here, because this makes sense if we're talking about people with the chronic IBS, the chronic IBD, these chronic constipation diarrheas. They show up with this pattern. So you're getting a health history, you're seeing all the pieces. How does this relate to someone who doesn't really have symptoms, but sometimes alternates, has a week where they are more constipated or a week where they have more loose stools? Is there a way to kind of explain how that might play into that pattern?
Yeah, that's a great question. So we can still use the StoolOMX to get good insights there. And you can also use it as a rule out to kind of see, okay, are bile acids an issue with that alternating pattern, or is it something else? Maybe it's more related to overgrowth or, upstream root causes, or maybe there's other aspects of digestion that we need to address. Do we need to look at pancreatic enzymes? So in that case, sometimes if we don't see a lot of imbalances on StoolOMX, it's still valuable because we can kind of use it to rule out, okay, maybe this isn't the focus and we need to look elsewhere.
Great. Thank you. All right. So in continuing with that, so we're talking about the bile acid malabsorption. Do we have too much, too little? How is that typically addressed? And what are strategies to address low bile acid levels or too much? So moving forward, we've got these test results. We see these patterns. What are some of the things that are best, what are the best strategies for us to use with our patients and clients?
So I'll start with the low levels. That might be a little bit more straightforward. Typically, if we're seeing low, we're thinking about if there's low output from the liver. And so there we might think about liver and gallbladder health, maybe bringing in things like digestive bitters or bitter herbs, cholagogues, artichoke, bitter greens, beets, lemon, to just help stimulate that bile flow. Some folks will also consider the use of bile acid supplementation, things like TUDCA, to really help with more of that stimulation. Then on the other end, we have the bile acid malabsorption, we have excess. So kind of step one there is sussing out a little bit of what's the root cause, why might there be this excess? So do we think it is due to a disrupted feedback loop? And things like inflammation can definitely impact that. Do we think it's malabsorption? Do we need to look at the integrity of the intestinal barrier? Is there overgrowth of inflammatory microbes? That can all have a big impact. So that's kind of step one, is why do we think there's high primaries? Yeah. But then we want to deal with the high primaries themselves. So the conventional method is through the use of bile acid sequestrant medications, things like cholestyramine, and that helps to bind to those excess bile acids. Now, they can be poorly tolerated. They can come with side effects. Sometimes compliance can be a little bit lower. So that's just a clinical challenge to be aware of. But in functional medicine, of course, we can think about all the tools in our toolbox that we have available. So we might look at alternatives, other binders. That could be things like activated charcoal, psyllium husk, ground flaxseed, to again kind of help bind up that excess.
Yeah.
Lecithin could be another tool to sort of buffer against the irritating effects of primaries. They can be really irritating to the mucosa and kind of contribute to increased inflammation. And then we can think about dietary approaches as well. So fiber is a big one. Fiber can bind to cholesterol, so that further upstream can kind of help with that bile acid synthesis if there's just excess production. We can also think about if the commensals are low. So if we're seeing this imbalance of high primaries, low secondaries, do our commensal bacteria need some help? So we can bring in a diversity of fibers, thinking about polyphenols. And I always challenge folks to look at not only the level of fiber that they're consuming, but also the diversity. You know, you might be doing a nice job of getting a nice amount of fiber in daily, but is it the same 5 to 10 foods? And can we really diversify that for the health of our microbiome? And then we also know that fiber can have some effects against some opportunistic overgrowth inflammatory microbes in the small intestine. It can inhibit things like Klebsiella, for example. So if that inflammatory dysbiosis is playing into the malabsorption, making it more difficult for those primaries to be absorbed, fiber could be, you know, one tool there. From a fat perspective, dietary fat is that trigger for the release of primaries from the gallbladder. And so thinking about what does fat intake look like? Do we want to trial a low-fat diet to influence that feedback loop? So those are kind of dietary pieces. I can keep going.
Yeah, well, let's stop there for a minute, because what I love is that you brought it back to food. Right? Because I feel like sometimes in functional and integrative medicine, we're all excited about the testing, we're all excited about the protocols, and we're like, okay, you need to do this, and this is the protocol you're going to follow, and then we're going to test this, and we're going to find this. And a lot of this really comes back to our food choices.
Mm-hmm,
absolutely. And so I thought that was super powerful that you brought that up. Let's just talk about food for a minute, because that's my favorite thing to talk about. But right? I mean, I love it. And we talk about food, but fiber is really exciting. And what are our best sources of fiber, right? We think about that as, okay, we can get them from beans and legumes and grains, but fruits and vegetables are pretty powerful here.
Yes, absolutely. And again, looking for that diversity. So I love challenges of either having clients write down the foods that they're eating or looking at a color wheel and kind of keeping track of all the different colors. And that can be a helpful and kind of gamify it in a way, a fun challenge to see, oh, okay, I'm doing good with orange, or maybe I'm eating a lot of beige foods, but polyphenols, as I mentioned, are really impactful for the health of our microbiome. So are we getting those deep pigments of red, purple, blue foods? So really kind of step one for me to simplify it. Of course, fibers can get so complicated, and there's different microbes that prefer different types of prebiotic fibers. But from a food-based perspective, I think a nice first step is just looking at how do we get better diversity in. If you typically go for this color of fruits and veg one week, can you go for a different, or are there ones at the grocery store that maybe you haven't tried before, and really expanding that there?
Yeah, thank you for sharing that, because I think it's important for us to remember that our food choices matter. And when it comes to fiber, variety matters, colors matter, and that we need to be incorporating those daily and switching things up weekly. So I love that you brought that up, and gamifying it and trying to try new things, because I find that if it's fun, if it's like, just pick a new vegetable, just try it. It can be pretty impactful just through food. So that's awesome. All right, let's shift a little bit and talk about short chain fatty acids. So can you tell us what they are, where are they in our GI tract, how are they produced, and what are the beneficial health effects of short chain fatty acids?
Yeah, so great segue from our conversation on food, because we need fiber to also produce our short chain fatty acids. So the short chains are fatty acids that have small carbon chains. They are also produced by bacteria. So again, we have the two different groups. We have the straight chain, and those are produced when bacteria ferment fibers, carbohydrates. And then we have the branch chain. So that's when there's protein fermentation by those microbes. And very similar to the bile acids, there's certain microbes that make all of these metabolites. Some are measured on GI map, some are not. And so we do get that broadened view of the health of the microbiome there. These are produced, most should get absorbed, but then again, we're looking at what is not absorbed in stool. And so keeping that physiology in mind when we do interpret the results. But these have a whole host of effects. I alluded to a few already. So short chain fatty acids can impact the pH within the gut. And so that can really impact our microbiome balance. It can help to inhibit some of those more opportunistic or pathogenic microbes. Short chains can also act on receptors, very similar to the bile acids, and that is how they elicit some of their effects. They can stimulate GLP-1, PYY, so we can have effects on appetite regulation, helping to maintain energy balance. We can also see anti-inflammatory effects. They help with intestinal barrier integrity as well as motility. So quite important to have for proper gut health.
I'm kind of liking this. This can help my appetite, my metabolism, and bowel motility all at the same time. This is amazing. All right. So we know that they're important. We know where they're produced. What insights can the short chain fatty acids section on the StoolOMX add-on provide? So what do we see? So when you're looking at that add-on, you see the results. What are we looking at, and what can we kind of determine when we see those results?
So again, we have the two parts. We have the straight chain, we have the branch chain. So in terms of diet, bringing it back to diet, the straight chains looking more at fiber, branch chains more at protein. And so if we have imbalances there, we can look in the diet and see, okay, what is the balance between protein and fiber? Do we have low fiber, high protein? How's digestion of protein? If folks aren't breaking down their protein as well as they could, do we need to bring in some additional digestive elements to help with that? So this section can provide insights into dietary composition and also maybe the opportunity if there needs to be modifications to the diet. In terms of other health effects, so big impacts with motility here too. If we see imbalances in this section, if there are higher levels, for example, of the straight chain fatty acids, often that can be related to fast motility because things are just moving through the GI tract too quickly for those to be absorbed. And so we're seeing them in higher levels in stool. And so we can get some insights into fast transit. If there's low levels, sometimes that can be slow transit. Slow transit could be higher, low levels, depending on how well things are being produced and absorbed. Often we'll see higher branch chains with slower motility. If we think about where some of these products are produced, straight chain tend to be produced more at the start of the colon, branch chains further down towards the end of the colon. And so with constipation, often we see this kind of switch in these higher levels of the branch chains. So we can get some good insights there into motility. And then one of the other concerns with the branch chains is when bacteria are doing that proteolytic or protein fermentation, they can also produce other compounds like ammonia or precresol, which are not health promoting. It's not what we want to see. And so one of the concerns with high branch chains is, are these other compounds also being produced, and do we have higher inflammation, especially if short chains are lower? Those are very anti-inflammatory. So now is there an imbalance and we have more of a pro-inflammatory state?
Okay, so now I'm going to dive back into the food section. So if we have that higher branch chain fatty acids, does that give us an indication that there might be a high protein diet and maybe not enough fiber in the diet? And so one of those things might be, how do we diversify our diet or balance out the diet? And the same vice versa. If we don't have any of them, maybe someone's not getting enough protein. Would that be something we could actually assume or consider when we see these results?
I think so. Yeah. I mean, again, we always want to look at the results in context of the patient. And I would say with high, it could be high protein diet, certainly. I would also definitely consider how well a patient is digesting. So that might be looking at other elements on the GI map. Are we seeing clues of maybe low stomach acid and needing to support that? And maybe they have a proper amount and they're not necessarily high protein, it's a well-balanced macronutrient ratio with the fats and carbs, but maybe they're just not digesting food very well. And that's more the focus that we need. So I think we can look at the results but really get those good insights when we dig into the patient history and have an idea of where are they starting, because then that can help us to know where we want to take them.
Okay, that's awesome. Thank you. Quick question. Can we supplement with short chain fatty acids?
We can, yeah. So the biggest one that we talk about is butyrate. So we can certainly use butyrate supplementation, and that can be helpful for a whole host of things, anti-inflammatory. We often talk about it for its pro-motility effects. So that's kind of the biggest one. And then indirectly, I would say looking at the health of our short chain fatty acid producing microbes on GI map. We can look at Faecalibacterium protsnitzi, Roseburia, and then the Firmicutes phyla to get a sense of, do we have enough commensals that are capable of producing these? And do we need to bring in supplementation or food to help their growth? So that might look like polyphenols, that might look like prebiotic fiber supplementation. So I think there's, direct and indirect ways to influence that short chain fatty acid composition.
Awesome. Thank you. And then what are your top tips for integrating bile acid into your clinical practice? So we can supplement with the short chain via an actual supplement or food. And how about the bile acids? If someone needs some support, what are your top tips?
So with low bile acids, we can think about, again, liver support, and that might be gentle. It might be milk thistle, or again, looking at those bitter foods in the diet. There are things like ox bile or TUDCA from a supplementation perspective. And then with excess, looking again for those binding properties. Certain probiotics have also been shown to help modulate the microbiome. So that can kind of change the bile acid pool. They can also impact bile acid synthesis. So maybe thinking about even the use of different probiotics.
Okay, wonderful. So as a clinician practitioner, how do you know when you should add on the StoolOMX panel to your GI map versus running just the GI map alone?
That's a great question. I would say a big opportunity is for your patients that do have that altered motility. So either the chronic constipation or the chronic diarrhea. Again, a large portion of patients that have IBS-D, and sometimes that can be a diagnosis of exclusion, and there can be a large differential diagnosis list for diarrhea. And so this can be a nice way of, again, ruling in or ruling out, are bile acids implicated there? So I would say that's a big population. We do see patterns with inflammatory bowel disease, so that could be a nice patient population as well. And then there are effects on metabolism. And so your metabolic patients, there can be opportunity there too, to get some additional insights.
Okay, that's great, because that's what I was going to ask. If we can see some of those patterns on this add-on, does that help explain some of the symptoms beyond what's showing up on the GI map? And I think you answered that. So we get a little more insight. We can take that history and understand, and then, come up with the proper protocol. Okay, are bile acids and short chain fatty acid imbalance is something you see more commonly in certain client populations?
So definitely in those that have bile acid malabsorption, of course, like the IBS-C. We do see them in inflammatory bowel disease, and actually the imbalance there. So with IBD, a typical pattern can be high primary bile acids, low secondary bile acids. And the act of having the higher primaries, again, they can be really irritating to the mucosa in the colon. And so that inflammatory action is actually thought to be involved in some of the inflammatory pathophysiology of IBD. So we can think about patterns there with those patient populations. I would say those are kind of the big ones to consider.
So in practice, can you share with us a case study or a specific patient's, experience that they came in with kind of a crazy story and some ongoing chronic GI issues? And what were you able to see in the GI map plus the add-on StoolOMX and move accordingly? So we can see, what does success look like when you actually run this panel and help someone with the insights?
Yeah, so we had a member of our clinical education team that actually presented on this earlier this week, had a patient with diarrhea urgency, ran the GI map, had some high candida, certainly some imbalances within the GI tract and dysbiosis to work on. But then on the StoolOMX, they did see a high percentage of those primaries, low percentage of the secondaries. And so in that case, they addressed the candida. There is a connection, interestingly, with candida and bile acids and actually the short chain fatty acids as well. So addressing the candida, kind of looking at balancing out the microbiome, but then bringing things in like fiber and butyrate, and that really helped move things in the right direction.
Oh, that's great. So in that case study, and in just kind of in general, is there an approach you take as far as what you try to work with first? Like in this case, if there's candida or an overgrowth that you see, do you work on that first? Do you work on the, gut lining first? Do you work on the bacteria first? Give us some insight that are best practices.
That's a great question. And I will say it's not one size fits all.
Right.
Unfortunately, we want that answer of like, do this.
I know. Come on, Jen.
I know. My answer to so many questions is it depends.
Right. Well, thanks for nothing. No, I'm just kidding. I'm kidding.
No, but I think, what we can consider is what are the presenting symptoms? Do we want to do some symptom management there? What do we see on the GI map? So if there is a lot of dysbiosis and with malabsorption, there can be an influence of inflammatory microbes, especially those that produce biofilms. So if they're producing biofilms in the small intestine, that can make it more difficult for absorption. And so in that case, if that's the root cause, it might make sense to go after and kind of do an antimicrobial protocol first. If it's more a factor of dietary changes, maybe working with that first as well. And a lot of these steps can also be done simultaneously. I think sometimes we think of, okay, step A, step B, and isolated steps, but really there can be a lot of interconnections where maybe we're shifting the diet while also addressing some of that overgrowth. I'll also say there can be this two-way street or kind of bidirectional relationship with transit time. And as part of taking a robust patient history, it's really, really helpful if you're running the StoolOMX to know what transit time is like for your patient. As we talked about, these products can influence motility, but then motility can also impact how much time is available for that absorption to take place. So sometimes patients might also need to work on, especially if it's slow motility, for example, maybe that's kind of an earlier step, is bringing in some pro-motility agents, whether that's like magnesium or ginger or 5-HTP or whatnot, to kind of get things going a little bit, bringing in some digestive support on board. So probably not the clearest answer you were hoping.
That's okay.
Because that means
I got a couple of new questions for you. So for those who've never done it, what is a transit test, transit time test? How do you perform that? Or how do you help your patients understand or assess so they can report what their transit time is?
So probably the easiest is through food. So either taking something like corn is a big one, so consuming corn. Some folks will use beets. I've also seen like sesame seeds. Using I imagine you could use flaxseed, not ground, but you want something that's not going to be fully digested. So consuming that, making note of when that is, and then also making note of when you see it in stool. And that can give you a sense of what transit time is looking like. Typically for loose stools, we can kind of assume transit is quick, but
Right.
more constipation, it can be helpful to see, okay, exactly, how long is it taking from consumption until stool to see that food.
And what's a good transit time for those who may have not heard this before or maybe need a refresher? What's the transit time we want from the time we consume the food to the time it comes out?
That's a great question, and it can vary, but I've seen figures anywhere from like 18 to 24 hours. When we start getting into longer time, that's definitely, we're getting into much slower transit. So I would say kind of around that 18-ish plus.
Okay.
On either end of that.
And that's an interesting one. I had a twisted colon, so I had my ascending colon removed. So I lost 12 inches. So I actually try to pay attention to transit time because I have less colon now, which is really interesting. So I'm always like, is it my colon or is something else up right now? Right. Because I've lost part of my short intestine, not my colon. But no, my colon, my ascending colon. Yes. I'm like, what did I lose? Yes, 12 inches of my ascending colon.
Okay.
Yeah. So that was super fun. Or not.
Yeah.
But let's transition to one more question I have based on our cool assessments and our patient intakes. We have all of this information. We're starting them on reducing inflammation, supporting digestion, all of the things. When do you retest with a test? And how do you assess their symptoms throughout the process? Like, how often would you recommend? Do you recommend symptom assessment along the way? What does that look like? Because sometimes these costs of these tests can add up, right? Sometimes it's really important, but what's the best practices there?
For sure. So I personally always have clients jot down some notes when they first start working with me, because I feel like it's easy to forget how far you've come. And it's easy if you have chronic symptoms to kind of normalize things. And so as people feel better, they might forget, oh, wow, this is where I started. And especially healing's not linear. And so maybe we're making strides, but then if there's a little bit of a setback, sometimes that can be discouraging, but it can be helpful to say, but look, like where we started, we've made so much progress. So I like taking notes. I think questionnaires are helpful in kind of tracking over time. In terms of retesting, if you're doing any sort of antimicrobial work, and typically if it's herbal protocols, that might be a couple of months, we do recommend doing a washout period. So ending antimicrobials, waiting a period of time, and then retesting. And that just allows time for things to kind of settle down, for us to get a better sense of, okay, was the protocol successful, or maybe it looked really good right after, but then are things kind of coming back? So I would say, waiting about 4 to 6 weeks after the end of an antimicrobial protocol to retest. If patients are working a little bit more on just rebuilding, so maybe commensals are really low, they're working on barrier integrity, giving that a good 3 to 6 months and then retesting. Some patients, if they feel great, they might decide not to retest, but if they want to check back in, see how things are doing, especially if folks have pathogens, for example, sometimes they want to make sure, those are on. And so we can use that, or, if things aren't moving as well as a patient would hope, if there's still lingering symptoms, then that retest can be a really nice check-in.
Wonderful. All right, let's transition to our audience Q&A. Thank you to everyone who's been posting questions in the comments. We're going to get to as many as we can. And if you're watching this as a replay, feel free to post your questions in the comments. Don't forget to subscribe so you never miss a live stream. All right, let's get to some of these questions. Okay, where are they? I'm waiting for them to pop up. Here we go. Okay, here we go. Question number 1. How might short-chain fatty acid patterns influence recommendations for fiber intake or probiotic selection?
Great question. So if we see low short chain fatty acids, and especially if we're looking at the GI map as well, and we see low short chain fatty acid producers, so that's going to be things like the Faecalibacterium protsnitzi, the Roseburia, looking at Firmicutes, that can definitely be an opportunity for increasing fiber. With the short chain fatty acid producers, that could be things like resistant starch or certain things like sun fiber. In terms of probiotics, they can have a modulating effect on the microbiome. So again, depending on the levels that we see, we can use certain strains to maybe help increase lactobacillus or bifidobacterium, which might produce certain short chains, but also can produce metabolites that other bacteria, other short chain producers will then consume as well. So I would say, looking at the low levels there. And then if we're getting a sense with the short chain, so if there's high levels, if we think there's fast transit, if we know from symptoms there's fast transit, certain probiotics can also help to kind of modulate transit as well. And so that might be beneficial. Thinking of short chains, they're also so helpful for barrier integrity. So if that's a clue, and we're seeing on the GI map other clues of, hey, there might be some leaky gut here, certain probiotics can also be helpful for barrier integrity and kind of that leaky gut healing step.
Wonderful. Thank you. Okay, here we got one. How do you integrate StoolOMX results with other labs, such as organic acids or hormone panels when you're building a protocol? So what are some of the things you're looking for when you have a series of lab tests, and how to draw conclusions and correlations between multiple tests at one time?
That's an excellent question. And I would say I would expand the StoolOMX to include GI map as well. So looking at the patterns of how that all can connect. So things like organic acids, we are looking at, on our organic acids profile, we're looking at certain microbial metabolites. So we can get indirect indications there of dysbiosis. And so that can pair really nicely with the GI map. In terms of things like hormone panels, for me, something that comes top of mind, especially with constipation, is the reabsorption or the excretion of certain hormone metabolites like estrogen metabolites. So with the GI map and StoolOMX, we can look at things like beta-glucuronidase. That's an enzyme that helps with that excretion. So if that's elevated, and again, if we have that slow transit, that can impact perhaps how much our detoxification abilities. And so I think there's a lot of opportunities there to have this synergistic play of the different markers. Inflammation's a big thing as well. We talked a lot today about inflammation. We can look at inflammation deeper on other panels as well to get a sense of, systemically what might be going on.
Wonderful. And do you find that in some of those patients, it is better to actually have a couple of different tests so that you can draw correlations between all of them?
I think so. I mean, I'm a data person, so I like, test, don't guess. So I think it's helpful to get those insights. And, when we're looking at different tests and we're looking at, blood versus stool, we can get different insights there too. So it can really help to kind of round out the story depending on someone's symptoms, and especially if they have some systemic imbalances.
Right. Amazing. Okay. For practitioners who are new to using these markers, what's the best first step to start incorporating the StoolOMX data without feeling overwhelmed? So most practitioners have a series of tests that they're comfortable with. And so those are what they run all the time. But now they've listened to this podcast and they're like, oh gosh, this sounds like something I should be doing. How do they incorporate that without the overwhelm and know that there's some simple steps to take? What's the best step?
We tried to make this panel as user-friendly as possible, while also showing that, there are a nice abundance of especially the bile acids that we can look at, and research is expanding there. So we've broken the panel up into different pages. So we have a really nice summary page, and then we go into and measure and report all of the different analytes. So to manage overwhelm, stay on the summary page. That's a really nice kind of way to get that high level view. There we're looking at totals, we're looking at percentage balance. And so that's a really nice snapshot. You can see right away, are things really out of balance, or are things looking okay? And then as you build that comfort level with the StoolOMX add-on, then you can kind of get further onto the next page, look at all the bile acids, kind of look at the breakdown of primaries to secondaries, look at the back page, look at the straight chain to the branch chain. But to start out, summary page is where it's at.
Okay, thank you. That makes me feel more excited about it. And I think that's what a lot of practitioners feel like. They want to incorporate new testing and they think this is amazing, but oh gosh, now I have to learn something else. All right, we have another question that just came in. Are there any red flags in short chain fatty acid results that suggest a more systemic issue beyond the gut, like inflammation or metabolic dysfunction? I feel like I know the answer to this, but I'm going to let you answer it, Jen.
Yeah, that's a fantastic question. And I would say, we don't want to look at that section just in isolation. So looking at the rest of the GI map too. But again, if there are elevated results, if we're thinking of fast transit, of inflammation, of a lack of absorption, we can think systemically as well, and looking at the GI map, do we see other red flag markers? Is there high calprotectin? Is there occult blood? Are we suspecting that there might be celiac? Beyond looking at the short chains, looking at the branch chains, if there's a lot of malabsorption there, is there something going on, like a celiac that might be impacting that absorption? So I think that using it in context of some of the other markers that we have with the whole test, GI map plus StoolOMX, that can be really helpful in kind of seeing, okay, are there areas where we might need to do a little bit of a deeper dig?
Amazing. Thank you. All right. We have one more that's come in. Can bile acid malabsorption, which we've talked about, look different when in clinical presentation compared to low bile acid production? So low bile acid production versus bile acid malabsorption. How do you distinguish between the two?
Yeah, that's an excellent question. And so we do always want to remember we are looking at these metabolites in stool. And so thinking of, what all has occurred prior to seeing it in stool. And that's where having just a general idea of the fundamentals of what normal physiology is can be really helpful in creating that framework for then looking at results. And we want to look at symptoms as well. But yeah, when we have low bile acid production, if we see it low in stool, we're thinking it might be liver, but it can be helpful. Again, we want the patient presentation. We want to know what their transit's like. We can look at other symptoms, other tests to get a sense of, do we think that there are any concerns with liver health, with gallbladder health, and then with the malabsorption as well. Again, looking at stool, we can make those inferences of, there's malabsorption, looking at the other clues on the GI map too. And so I would say, again, we want to really broaden the context, consider patient presentation, but other markers on GI map as well. But typically with malabsorption, again, it's going to be more of like your fast transit with lower bile acid production. Typically the patterns that we see are going to be a little bit of that slower transit.
This is great. I love all of the information you're sharing, and I love that you bring it back to some of the foundations. You need to have a really in-depth patient intake, so understand what's going on, what's their diet like, what's their transit time like. Also having an understanding of how the digestive system works, right? There's a lot of steps to the process. It's not just a stool test. We have to think about what's happening in the stomach with stomach acid, what's happening in the small intestine. Do we have enough enzymes? Do we have enough bile? So I love that you brought that all together, because it's not just as easy as, let's run a test and that's going to help us figure out the whole problem. So thank you for sharing that. This has been a great discussion, and I'm grateful for all the work you do, Jennifer. Where can people find out more about how they can work with DSL and start working with StoolOMX and the GI map?
Thank you so much, Lainey. The easiest Place to find us is our website, diagnosticsolutionslab.com. There you can find much more about the GI map as well as the StoolOMX add-on. We have a really nice interpretive guide that goes through and discusses a lot of what we went through today. But, what does it mean if markers are high or low? What are some things that you might think about? On our website as well, we have a resource library, and our clinical team has been very busy creating a lot of really nice, helpful resources to help clinicians build that comfort level with StoolOMX to kind of, be more comfortable, to conceptualize the primaries, the secondaries, all those good things. So I would say, find us on our website, and then we're also busy on social media as well, creating some good clinical content there too.
Wonderful. Thank you. All right. If you are listening to this podcast, be sure to hit subscribe so you don't miss any of our live streams. And guess what? In 2 weeks, we're going to be live in San Diego, and Jenn is going to be presenting at one of our Lunch and Learn sessions. So you can find more info at hicks-live.com and still get tickets at 15% off if you add the code HICKS15 through the end of the month. Thanks for joining us today. And Jenn, you've been wonderful. Thanks for being here. And I can't wait to see you in a couple of weeks at Hicks Live.
Thank you so much for having me, and I'm looking forward to it.